Hello, everyone, and welcome to this session on violent agitation and excited delirium in the pre-hospital setting. Today, we'll explore how to recognize and manage severely agitated or combative patients in the field, with a focus on safety for both patient and provider and current best practices. Violent or wildly agitated behavior can be one of the most challenging scenarios EMS professionals face. In this talk, we'll discuss common causes of agitation, effective de escalation techniques, the controversial concept of excited delirium, and how to approach these incidents safely and professionally. By the end, you should feel more confident in handling these high risk encounters while preserving patient dignity and ensuring everyone's safety. Let's get started. Agitated or violent patients are relatively rare, but they pose disproportionate risks during EMS calls. As an EMS professional, you might only occasionally encounter a patient who is physically combative or extremely agitated, but when you do, the stakes are high. These situations can escalate quickly, leading to injuries for the patient, crew, or bystanders. It's critical to approach them as medical emergencies rather than purely criminal or social problems. A severely agitated person may be suffering a life threatening condition that requires our help. Your role is to rapidly recognize when a patient's aggression or bizarre behavior stems from a medical cause to protect everyone on scene and to begin appropriate management and transport to definitive care. Ensuring safety is paramount, but we also have an obligation to treat the patient's condition. This balance, safety and patient care, is the core challenge we'll be addressing. Let's first consider what can make a patient violently agitated. There are many possible causes, and often it's a combination. Intoxication or substance use is a major category. Stimulant drugs like methamphetamine or cocaine, as well as newer synthetic drugs like bath salts, can trigger extreme agitation, paranoia, and even superhuman strength. Patients high on these substances might be hyperactive, paranoid, and pain resistant, a dangerous mix. Alcohol withdrawal can also cause severe agitation or delirium tremens. Underlying psychiatric disorders can present with violent or erratic behavior. Patients with conditions like schizophrenia might have hallucinations or delusions that make them fearful or aggressive. Bipolar disorder in a manic phase, severe anxiety, or other psychoses can also lead to uncontrolled agitation. It's important to remember that a psychiatric history is a risk factor, but we should not jump to conclusions. Always consider medical causes too. Medical problems often underlie sudden agitation. Hypoxia, low oxygen, is notorious for causing confusion or combativeness. Think of a patient not getting enough oxygen who becomes belligerent as their brain struggles. Hypoglycemia, low blood sugar, can cause bizarre behavior or aggression. Other causes include head injuries or post-seizure states, where a patient may be combative upon waking up. Strokes, infections like sepsis or encephalitis, or metabolic imbalances, for instance, liver or kidney failure leading to delirium, can all manifest as agitation. In practice, when you see an agitated patient, keep an open mind. It might be drugs or alcohol, but it could be a diabetic emergency or lack of oxygen, etc. Your assessment should be geared toward identifying and treating any reversible medical causes as soon as you safely can. For example, if possible, get a quick blood glucose reading or consider administering oxygen early. However, safety comes first. Often, you can only address these causes after you've controlled the situation and restrained or calmed the patient. We'll talk about those management steps next. Whenever you respond to a scene involving a potentially violent or wildly agitated person, scene safety is your number one priority. Do not rush in without a plan. As you arrive, take a moment from a safe distance to size up the scene. Are there weapons visible or objects that could be used as weapons? Is the patient in a confined space or open area? Are bystanders or family attempting to intervene? Call for backup early. If dispatch hasn't already sent law enforcement, request them. Police officers are often crucial partners in ensuring safety during these incidents. Likewise, if you anticipate needing help, call for additional EMS crews or ALS, advanced life support, assistance early. A coordinated response is much safer and more effective than two EMS professionals trying to handle a violently agitated person alone. As you approach, try to establish a single team leader for communication. Often it helps if one person, ideally someone with a good rapport or a calm demeanor, is the one doing the talking, while others hang back. This avoids overwhelming the patient with multiple people giving instructions. Speak in a firm, calm voice and introduce yourself as medical help. Simple phrases like, "I'm here to help you, I'm not a police officer, I'm a medic," can sometimes lower the patient's guard. Keep a safe distance initially out of immediate reach. Watch the patient's body language closely. Warning signs of impending violence include a tense, rigid posture, clenched fists, pacing or inability to sit still, angry or paranoid words, and a thousand-yard stare or intense eye contact. Also, note if they are holding something that could be used as a weapon, or if there are dangerous objects nearby, like knives, glass, heavy items. If you see a weapon, retreat and wait for law enforcement unless it's absolutely life threatening and you have no choice. Remember, you cannot provide care if you become a victim. Ensuring scene safety isn't just a formality, it's an active, ongoing process. Have an exit route in mind. If the patient poses a direct threat and it's not safe to engage, don't. Wait for police to secure the scene. If at any point you or your partner feel unsafe, back out and reassess. No medical intervention is worth getting seriously injured. You can't help the patient if you're hurt. Whenever feasible, start with verbal de escalation. Your goal is to talk the patient down without physical force. This isn't always possible, but even if force becomes necessary later, establishing a calm tone early is beneficial. Here are some key techniques. Stay calm, supportive, and empathetic. No matter how bizarre or hostile the patient's behavior is, try to remain composed. Speak in a low, reassuring tone. Use the patient's name if you know it. Say things like, "I'm here to help you," or "I can see you're scared, angry. Let's talk about what you need." Show empathy. Even if the patient is being aggressive, they are likely in crisis or fear. A calm, compassionate demeanor can sometimes diffuse the tension. Use non threatening body language. Make sure your hands are visible and not balled into fists or occupied with something that could be mistaken as a weapon. Stand at an angle to the patient, bladed stance, rather than face to face squared off, which can seem confrontational. Avoid direct staring eye contact if it seems to agitate them further. Some patients find it threatening. Instead, maintain a neutral, attentive expression. Move slowly. No sudden moves that might startle. Respect personal space. Often agitated individuals feel threatened if you get too close too fast. Keep a bit of distance so the patient doesn't feel cornered. If you need to enter their personal space to assess or treat, explain what you're doing first. "I'd like to check your pulse to make sure you're okay. Is that all right?" If they refuse, back off and try again later or keep talking. Forcing it can escalate the situation. Listen and acknowledge. If the patient is shouting or ranting, let them vent, as long as there's no immediate danger. Try to pick up on any content in their speech. Are they scared of something? Do they think someone is out to get them? Acknowledge their reality without directly feeding any hallucination. You can say things like, "I understand you're hearing voices right now. That must be frightening, but I don't hear them. You're safe with us." This shows you take them seriously. Reassure them, "We're not here to hurt you." Reduce unnecessary stimuli. If lights and sirens are still blaring, have someone turn them off. Ask bystanders who are not helping to give some room. Too many people or loud noises can worsen confusion or panic. Ideally, you want a relatively calm environment to help the patient focus on your voice. Verbal de escalation won't work every time. Some patients are too far into their delirium or paranoia. But we always attempt it first because it's the least invasive and safest approach. Even if it doesn't completely calm the patient, it can buy time and build a bit of trust. And if things do escalate to restraints or medications, the patient may remember that you tried to treat them with respect from the start. That matters for maintaining patient dignity, which we'll continue to emphasize. How do we know when we're dealing with a medical delirium, like excited delirium or agitated delirium, versus someone who is simply violent or combative for other reasons? In practice, it can be hard to tell. They often overlap. But generally, delirium is an acute medical state of confusion and disorientation. The patient isn't in control of their actions in a normal way. They're not attacking people with a clear goal. Instead, they're reacting to terrifying hallucinations or the effects of drugs or a metabolic crisis. Recognizing this helps you frame the situation as a medical emergency, not a criminal act. Here are some clues. Extreme, unrelenting agitation, often with intense fear or panic. The person may be shouting incoherently, rapidly switching topics, or yelling random words. They might appear to be fleeing from unseen threats or severely paranoid. This level of irrational behavior suggests delirium. Profuse sweating and signs of overheating. Many patients in an excited delirium state have hyperthermia, meaning their body temperature is extremely high. You might notice they have flushed skin or are burning up to the touch. They could even start shedding clothing. Many cases note patients strip naked. This is a red flag that they're extremely overheated and delirious. Superhuman strength or endurance. These patients often seem unbelievably strong for their size, and they resist for long periods. You might see them breaking out of plastic restraints or needing 5 or more people to hold them down. They often don't respond to pain in a normal way. For example, even if they get pepper sprayed, tased, or physically restrained, they keep fighting without slowing down. One hallmark phrase emergency providers use is that an excited delirium patient can have imperviousness to pain. Altered mental status signs like not recognizing familiar people or places, speaking gibberish, or having hallucinations. They might be talking to invisible people or seeing things that aren't there. Sudden collapse after a period of intense struggle. A very concerning pattern that's been observed is when a patient fights vigorously against restraints or exerting themselves, then all of a sudden goes quiet and limp. This is often a prelude to cardiac arrest in excited delirium scenarios. Essentially, their body might abruptly decompensate after maximal stress, like a switch flips. If you see a sudden cessation of struggle and the patient becomes unresponsive, immediately check their pulse and breathing. They may have gone into respiratory or cardiac arrest, as tragically happens in some excited delirium cases. These signs collectively point to what was historically called excited delirium syndrome, a term describing a perfect storm of agitation, delirium, physiologic overheating, and potential sudden death. We now prefer to think of this as a form of hyperactive delirium with severe agitation, which I'll explain more in a moment. But the key takeaway here: if you see this cluster of signs, extreme agitation, bizarre behavior, hyperthermia, and incredible strength, treat it as a true medical emergency. The patient is in a dangerous state that can be deadly if not managed quickly. We will wrap up this section here. Join me on the next lecture in this series where we will discuss the dangers of excited delirium as well as how we manage these patients in the field. See you then.